Good afternoon, everyone. I hope you're well. Today's session is on shock. I can't see you, but hopefully at the end of this session, I'll be able to have a chat with you. This lecture is based on my personal experience and from a variety of intensive care literature. And by definition, there'll be a certain degree of bias in what I think should be included, excluded, and what is possible to include from the internet. Emmanuel has sent a 2021 paper on the management of sepsis and septic shock, which is on the discussion room. And it shows the difficulty of preparing the consensus document. So what I want you to realize, what I'm doing today is really trying to offer you a skeleton on the basis for shock management. And remember, with time, opinions change. Just last week, I saw a paper that said you should use ringer lactate rather than normal saline for resuscitation. And yet the paper I was referring to from Emmanuel says it doesn't really matter. And I guess for us, those are working in osteo conditions, really the latter may be helpful because it's pragmatic. You use whatever fluid you have in your location. Now, remember, you may have a variety of experiences and follow various guidelines from your own institution or employer. Just remember there is a subtle variation in practice from all over the world. And remember that whenever you talk about critical care, you have to take into account the diverse biopsychosocial variation in our patients. And this is what is a big challenge. So I hope today we cover in the next hour the principles of shock, the diagnosis, and the management. And at the end of the talk, there are about half a dozen slides which I found on the internet, which is for you to have a look at when you've got the time. So why does a shock occur? Well, if you look at the delivery of oxygen, so that's what the body, the heart, the lungs, and the vascular system tries to deliver to the various organs, will depend upon the cardiac output, which is stroke volume times heart rate. And the majority of oxygen is carried on the hemoglobin. So this is the really important bit, and a little bit that is dissolved in the plasma. So shock occurs when the delivery of oxygen is not adequate for the organs, and particularly the brain. The other problem that can occur in shock is, is ineffective tissue perfusion, and this will occur in sepsis. So in sepsis, unlike other forms of shock, you can have oxygen going to the tissues, but actually bypassing some of the vital parts due to problems in the microcirculation. And then the third aspect is when the mitochondria that is going to be responsible for converting glucose into ATP cannot actually utilize oxygen. And this occurs in cyanide poisoning. So if you look at the circulation here, you've got your oxygen coming into the from the lungs, passed to the left side of the heart into the tissues. Oxygen is given up, carbon dioxide is taken it back, right side of the heart, and carbon dioxide is eliminated. So if you look at it from a mechanical perspective, the blood is contained within the tank. Remember, 80%, I apologize for that, 80% is contained within the veins. You can have problems with the heart itself, which becomes a pump problem, either because the heart is not working as efficiently, or because the heart is compressed, like in tamponade or tension pneumothorax. And then finally, the third bit could be the fact that your distribution from your circulation is not working as well. And this will occur in things like neurogenic shock, and we'll discuss this in a second. One thing you need to know is that the stroke volume depends on three factors. The preload, which is actually a volume. This is why when you're considering shock, the first thing to make sure is that the tank is not empty. You need a certain amount of volume for the system to work. It will also depend on the contractility of the heart, and this will depend on the heart muscle and the electrical apparatus, and also the status of the septum and the valves. And then you've got your afterload, which is a pressure. This is the pressure that the heart needs to pump at in which to distribute the blood through the aorta from the left side or through the pulmonary circulation from the right side. So just remember this complex interaction. You need a certain amount of volume, you need the ability for the ventricles to contract, and you need that contractility to overcome the afterload, i.e. the pressure of the systemic vascular resistance in the case of the left-hand side, or the pulmonary vascular resistance on the right-hand side. Now, the definition of shock is an acute circulatory failure due to inadequate oxygen utilization by cells. And there is a concept that you may not be very familiar with, is a concept called cell dysoxia. That is, you're providing oxygen to the tissues and the cells, but the cells cannot take it up. This is like in the case of cyanide poisoning. And there are four types: hypovolemic, which is well known to you guys, because that's fairly common in trauma, distributive, cardiogenic, and obstructive. Now you have to remember that patients don't necessarily follow those four separations. It may be very difficult if you don't know the mechanism of injury as to what's going on. More importantly, you may be seeing a patient early on in the genesis of the shock, and they may look normal. An example could be a young girl with an ectopic pregnancy that has ruptured, presents as an acute abdomen, but all her vital signs seem okay. The blood pressure seems to be holding, and then suddenly everything goes pear-shaped. So it depends on when you're seeing them. Similarly, if you've got a late presentation, especially when there is poor medical health care, or there's been a great distance to travel, then you're more likely to develop a septic episode as a result of the delay. So it can be quite challenging. But the most important thing is trying to recognize that you've got a problem and optimizing that oxygen delivery, the DO2, that equation that we showed you in the previous slide, and treat the cause. So if you've got sepsis, you should really be giving the appropriate antibiotic within an hour of the patient's arrival as the ideal. And the way you know that you're doing well is by repeated assessment, documentation, and monitoring. Now, here's the question again. You've got delivery of oxygen, and it's dependent on the cardiac output, hemoglobin, and the saturation of the hemoglobin, and to a less extent, the amount of oxygen dissolved in the plasma. So you can see cardiac output is the main determinant of DO2. So if your heart rate goes down, then your cardiac output will go down because it's heart rate dependent. Similarly, if your stroke volume goes down, you can see that your cardiac output is going to be compromised. But when you look at hemoglobin, if somebody loses the hemoglobin over several months, like due to repeated small blood loss, worm infestation, poor nutrition, patients could be walking around with hemoglobins at 4 to 6 and be adjusted to that. But if somebody drops the hemoglobin from, say, 14 to 6, then you can imagine that that same amount of hemoglobin has got to go around the body faster in order to provide the delivery of oxygen. And this is shown by the critical DO2 at this graph on the top right-hand side. So for the first bit of oxygen delivery, it's supply dependent, and then it reaches a maximum. So roughly you need about 250 mils of oxygen on the average adult who is normal, and what you deliver is about 1,000 mils. So you can see that you've got a fourfold availability of oxygen, and only 1/4 of that is used. Now, dysoxia occurs at this point here. This is when you, as your oxygen delivery gets lowered down, you move from aerobic to anaerobic, and therefore less ATP, and therefore you're going to mess up cellular function, eventually organ dysfunction, and the more organ dysfunctions and the more organ failures you have, this will result in death. Different organs have different thresholds, so the heart and the brain is what we try and maintain during our resuscitation and our priority as organs. On the other hand, kidney and skin are more tolerant in that they are quite capable of going through longer periods of time in preference to the heart and brain. In fact, you could say that if the gut is perfused, and we'll come to this when we talk about gut function later on in this course, the chances are that the rest of the body will be provided adequately, and in particular the target organs of heart and brain. But each patient will also vary depending on their metabolic demand. For example, if you've got a temperature, you're going to require more oxygen. If you've got a major burn, you're going to need more oxygen. If you are, on the other hand, hypothyroid and you have collapsed, you'll need less oxygen. If you're hypothermic, you'll require less oxygen. And also depend on age, whatever coexisting diseases, and obviously medication. Now, the reason why we insist that hypotension is not required to define shock is because in sepsis and multi-organ dysfunction, the delivery can be adequate, but because of shunting around the microvascular systems, the oxygen actually doesn't get to the cells, and inflammatory mediators released by the sepsis can induce mitochondrial dysfunction, and that's known as cytotoxic shock. So it isn't shock in the four categories that we talked about, but I wanted to bring this to your attention because hypotension is not always regarded as necessary to define shock. So the four that we're referring to is hypovolemic, cardiogenic, obstructive, and distributive. And that is based on the classification of which of the components that we talked about in the diagram is primarily disturbed. If the tank is perforated and you're losing fluid, it's hypovolemic. If the pump is not working, it's cardiogenic. If there's an obstruction to the pump working, that's obstructive. And if the pipes are dilated unnecessarily, then you're going to get a distributive problem as you get in neurogenic shock. So hypovolemic shock is well known to you. Most of you have dealt with cases like this and you'll be familiar. But just remember, there are two kinds of fluid loss. One is that of blood and the other fluid loss from other sources. And these can be quite excessive. For example, in a burn and pancreatitis, the fluid loss from the intravascular space, which is what we are talking about, is massive. And it can be quite difficult to keep a check on this loss because all of these cells become leaky. This is why patients with major burns get very edematous, and this is why in a major burn we try and sit them up as much as possible so that the upper airway is not as edematous due to gravity. Now, the estimated blood volume in an adult is 70 mils per kilogram, and you can lose 10% of that quite easily because you do that when you're donating blood. You can lose up to 30% and still compensate, but after 30%, then you start running into problems. So this occurs when you've had an acute blood loss, excessive fluid losses, or third space loss due to leakage, like as in a burns or pancreatitis. So this is fluid that is lost out of the intravascular system into the interstitial tissues and will make things worse. So what the body does in the initial phase is just move fluid from the interstitial space into the circulation by increasing the venous tone, because as I said to you, that the veins hold 80% of the estimated blood volume. So the sympathetic drive will shrink the venous capacitance and inject some fluid into the circulation. Or you can increase arterial tone, increase heart rate, and increase contractility. So that's your compensation. That's what Mother Nature does. What you need to do is to stop the blood loss, stop the fluid loss if at all possible. Again, in major hemorrhage, you know it's just going to be the areas of major blood loss, blood on the floor and four more: chest, abdomen, pelvis, and long bones. And then once you've stopped the blood loss, then you try and replace the volume as ideally as possible. The cardiogenic shock has a high mortality, and it is actually more common than you think. Myocardial ischemia is the most common cause, especially in the anterior MI, because the amount of cardiac muscle that's involved in an anterior myocardial infarction. But if you look at the heart, it's got three areas: the cardiac muscle, the structural defect, especially if it's in the septum, atrial septum or ventricular septum, or if the electrical apparatus is not working as normal. So initially, you need to correct the underlying problem as to what caused it, and sometimes that may not be possible, especially if you've got a massive septal defect that occurs acutely. And then consider afterload reduction. That is, you try and reduce the pressure of that the heart and the ventricles need to contract to project the blood into the systemic circulation. So this is what we mean by afterload reduction. Obstructive is an emergency, and it's a mechanical problem. You guys are well versed with in it, because this is your differential diagnosis in things like tension pneumothorax or cardiac tamponade. But there are others causes of obstructions, things like valve thrombosis, myxomas, pulmonary embolus, or hypertrophic obstructive cardiomyopathy. And really, what you need to do is treat the obstruction urgently. And in your case, the only thing that you need to consider really is a tension pneumothorax and a tamponade. Distributive shock is a little bit more difficult because lots of things can cause it. The most common being the septic, and that's why I put it in bold, and also some toxins, anaphylaxis, again, neurogenic. But don't forget things like the endocrine disorders. If somebody is not working well, doesn't feel well, always think, is this a neurological problem or an endocrine problem? Your nerves work quickly. Your hormones are slower system to react. So always think of adrenal gland and the thyroid gland as not functioning in cases of hyper or hypo activity. Now, in distributive shock, the distribution of blood is really dependent on the arterial autoregulation, the autonomic nervous system, and the various vasoactive hormones that are released, like vasopressin, antidiuretic hormone. And the shock will occur if there is inappropriate blood distribution by vasodilatation, resulting in a warm periphery. So in other words, distributive shock is marked by warm peripheries. If you examine somebody who is critically ill, starting at their feet and working up the body, the more shut down they are, the colder they'll feel, and they become warmer as you reach the central components of the body. And what is slightly different from the other causes of shock, the cardiac output may be initially increased to try and cope with this maldistribution of blood, but eventually that too will fail. So the issue here is identifying what's caused it. So if it's septic, you need an antibiotic. Anaphylactic, you need to vasoconstrict the whole thing, and that is epinephrine or adrenaline, and provide the basic fluid resuscitation, which will vary from patient to patient. Now, the clinical signs can be subtle, and that's where I find the most challenging. I'm thinking of a young girl with a ectopic pregnancy who is not ruptured yet, but doesn't feel well. She's got a little bit of a hemorrhage, so she's got a severe abdominal pain, but there's absolutely nothing else to find. And those are the ones that I call small sick. And those are the ones that you just keep an eye on and prepare for the worst. So the clinical features are very unspecific. And I find that if you record these assessments on a chart, or even if it's homemade on a piece of paper, you can see the changes over time of the heart rate, the blood pressure, the pulse pressure, the urine output, the temperature, and those will give you some idea as to whether the patient's holding, getting worse, or getting better. And remember, the younger and the healthier you are, the more likely you are to be able to compensate. But the older you are and the age extremes, or if you're pregnant, you're more likely to make things difficult. So as I said before, hypotension is not essential, but it's quite a common problem. And we say that if the mean arterial pressure is below 50 millimeters in healthy adults, then organ perfusion, this applies to every organ. So the one that we're talking about now of prime importance is the brain and heart, is not going to be sufficient. Tachycardia. The reason why tachycardia is bad for you is that the heart is the only organ that is perfused during diastole. I'll say that again. The only organ of the body that has blood perfusion during diastole is the heart. Every other organ has it during systole. So if you have a tachycardia, the diastolic time is reduced because the systolic time doesn't change, and therefore at a heart rate of about 110 and above, you've got a compromise of myocardial perfusion. And the heart rate and the respiratory rate go hand in hand. If you see a tachycardia, you'll see a tachypnea. If you see a bradycardia, you see a bradyapnea. It's almost like these two organs, two systems are interlinked. And if the kidney is not going to be perfused adequately, you're going to get oliguria. If the brain is not going to be perfused, then you will be subjected to altered mental status as decided by AVPU. And that can be quite important when you're making a decision as to whether somebody's improving or somebody is getting worse. And then obviously impaired peripheral perfusion by the capillary refill test. Here are some of the hemodynamic profiles. I'm not going to go into every one because you need to study this on yourself. I just want to show you two things. One is look how lactate levels just go up in shock, and look at the differences in cold and warm peripheries, in distributive and in neurogenic. They are warm, but the rest they're cold. And the CRT is always greater than 2 seconds. So that's an important thing to remember when you're trying to make the differential. So your management is really to restore the DO2 and improve tissue perfusion. And we'll look at investigations in a second. But the most important thing is think pink. How do we oxygenate this patient? You can either increase the FiO2 or apply PEEP, or both. That's it. There is no other way you can do it. But if you remember the DO2 equation, hemoglobin is important. So you can see that there will be a minimum amount of hemoglobin that the body requires in a critical care environment. Next is vascular access. I cannot emphasize the importance of having the biggest potential cannula, intravenous cannula, in a patient that you are suspicious about, because flow through a tube is controlled by Poiseuille's law, where it is a radius to the power of 4. So in other words, if you've got a 1 millimeter radius tube and you've got another tube that is 2 millimeters, the flow is 2 times 2 times 2 times 2 in the second one. So what it says is a small difference in radius can make a huge difference in flow rates. And also the other thing that comes into account is what the viscosity of the fluid is. If you're putting blood in, it's going to be slower. If you've got some of this hypertonic, hyperoncotic solutions, the viscosity is going to be higher, and the length of the tube. So really, what you want is a thick, short tube to provide the best flow. Next is fluid resuscitation. How much? Enough. What is enough to maintain a CVP, maintain a urine output, maintain mental alertness, or think about just giving boluses, aliquots of fluids to see where the patient is in terms of the tank. The choice of fluids we'll talk about in a second, but something that you can do quite quickly is the Trendelenburg maneuver, and we'll illustrate this in a second, and cardiovascular drugs, which we will cover very briefly in a second. But the most important thing is treat the problem that caused it. So the time to definitive rescue will define survival of your patient. So if it is septic, the administration of an intravenous antibiotic, depending on what you think the sepsis is due to, is going to be vital. Similarly, in an obstructive situation where you've got a tamponade or a tension pneumothorax, the quicker you decompress the situation, the likely the patient to survive and do well. And monitoring, you'll cover this in future lectures. Intra-arterial blood monitoring, central lines, cardiac output. I put a question mark because there used to be a vogue when I was in training. It doesn't seem to be so much in favor. Ultrasound is becoming more popular. Arterial blood gases, and as I said, lactate. And lactate is not that simple. And in one of the slides, which I shall not be covering in the lecture, but is in the end of the slides, is a whole page on lactate. What is lactate? How it's produced? What are the alternative sources? And how do you interpret a lactate result? So the important thing is to restore the DO2 by trying to alter the cardiac output, the amount of hemoglobin, and to improve the saturations by either increasing the FiO2 or applying PEEP or both. The amount that is carried dissolved in plasma is small, and for all intents and purposes, it's not that critical. So the investigations that you would do in a hospital would include a complete laboratory screen, and you can see it just covers everything: toxicology, cultures, coagulation. It just is a blunderbuss cover for everything. And you'll obviously have radiology, which goes from an ordinary chest x-ray to a trauma series if it's hypovolemia or trauma case, including CT and angiography. For example, if you've got a ruptured spleen, you may not need a surgeon. You may need a very sophisticated radiologist with invasive angiography who can then plug the bleeder in the spleen and avoid surgery. So this is what can happen in a critical care unit. This diagram is taken from it's taken from one of the slides at the end of this lecture, and you can see what a difference it makes in flow rates by just increasing the radius of the tube or cannula, and you can see a short but thick tube will deliver more fluid. And I can't emphasize the importance of having large cannulas in. And for me, in a situation where I think things are bad or going to be bad, I think a 14 gauge is my minimum. Now, when we talk about fluid resuscitation, there are two things I want you to consider. The first is Starling's law. If you increase the amount of fluid in the tank, that's the preload, the volume, you'll get an increase in the stroke volume. But there is a limit, okay? You can't just go off in a straight line. And obviously, the normal curve will be there. If you've got an increased contractility or a decreased afterload, you'll get a higher stroke volume, in which case you may need to diurese the patient. Or if the patient has got a shutdown systemic circulation, very vasoconstricted, or the heart is not contracting, the fluid bolus is not going to make much difference, and you're just going to give small boluses before you can realize that the fluid replacement is not the answer. And what we are trying to avoid is getting into this situation where it makes no difference, and that is cardiogenic shock. The second is to see what happens in a capillary. It's the hydrostatic pressure that pushes fluid out into the interstitium, and oncotic pressure of the proteins contained within the blood that brings it back into the circulation. And any excessive fluid will then be transferred into the lymphatic system. And this can be overwhelmed, like in a burn, a major burn, or say in sepsis, where you see red lines going up the arm or up the leg, where all the pus cannot be transferred within the blood, but needs to be transferred within the lymphatic vessels, and therefore the lymph nodes get more swollen and get very tender. Now, the challenge is, what is the best fluid and how much? Well, this is easy to answer. How much is enough? And that's the critical care is very simple, because any question I ask you, how much, the answer is enough. The difficulty is having the knowledge to apply how much is required for an individual patient with an individual problem. And you've got to bear in mind the difference between hypovolemia, not enough fluid in the tank, versus hypovolemia, which is too much fluid in the tank, both of which are bad. If you've got hypovolemia, you're going to knock off your kidneys. If you're hypovolemia, you're going to knock off your lungs, because the distance between the alveoli and the capillary is going to be increased, and therefore oxygen transfer is going to be made more difficult. And that's what PEEP does. PEEP squeezes the fluid out of the alveolar capillary space. So when you give a fluid challenge, say a 250 ml bolus, it'll depend on the Frank-Starling law as to how much of a response you're going to get. But this is complex because lots of factors play into it. So really what I'm saying is, given small aliquots of fluid, 250 ml boluses, and look at what the response is. That will give you an idea as to whether you're winning or not. Now, the fluid choice, like I said to you right at the introduction, here are some of the choices of fluids. You've got your colloids, your crystalloids, your red blood cell concentrate or packed red cells, your stored plasma, proagulant mixture, and platelet concentrate. Now, in blood loss, ideally, you want to replace blood 1 for 1. But the reality is that if you've got a major hemorrhage, you'll first go for the red cells, because that's what you've got. But then you're going to, that's the volume resuscitation. But then you're going to have to consider the coagulation resuscitation by giving fresh and flow plasma, cryo, and platelets. And the ratio of those will vary from place to place. But the everyday fluid to go to is crystalloid, and crystalloids were made up of electrolytes, water, and occasionally dextrose. Remember, dextrose-only solutions are not for resuscitation, because once you've used dextrose, you've just got water. So basically what you're doing is putting red cells into water and they'll hemolyze. So this is where it's important that when we're talking about the fluids we use, it's either saline 0.9% or ringer lactate Hartmann solution, which are both isotonic. Now, when you put in a liter of, say, saline, after it goes through all the compartments from intravascular into the extracellular, intracellular fluid, only about 300 mils will be left in the intravascular space. And the reason why we don't use saline as much compared to ringer lactate is because of that small risk of hypochloremic acidosis. But to be quite honest, it doesn't make a difference if you just happen to have just that one solution. So make sure that the solutions you're using are isotonic. The problem with Hartmann's, it contains lactate. And so if you're giving blood, you will not be able to, because blood contains citrate, it will interact and you may have to flush the line first. Hypertonic saline became popular about 20 years ago with special forces, because they thought if it's hypertonic, then it's going to pull fluid from the interstitial tissues, and for a small volume, you're going to get a large circulating volume. So almost double the figure if you use 7.5%. Unfortunately, 7.5% saline is very irritant and can only be given centrally and cannot be given peripherally. And it takes a long time to work. So for our purposes, perhaps not a very good idea. Albumin solutions, the normal one is normally 4%, is iso-oncotic. In other words, it's got, as you saw, the crystalloids were isotonic, in other words, electrolytes. Now we're talking about iso-onconic, which is basically protein, which can pull fluids in. And again, it takes a long time to equilibrate. And so for our purposes, we don't use it. We now use it occasionally in burns and occasionally in major hemorrhage when you're really pouring lots of fluid, say 3 liters plus. You might sort of buy some time by putting in a little bit of albumin. Starch solutions like heterstarch or dextran or whatever other commercial ones, they are oncotic, just like albumin, by their molecular weight. And they're broken down by the serum amylase and then the fragments cleared by the kidney. So it'll depend on how big the molecule is and how they're cleared. They can increase intravascular volume, but it's becoming less used, especially since we realize that it increases the morbidity and mortality in sepsis. And the other problems with starch solution, it makes clotting more difficult, and it can make blood typing a little bit more difficult. And finally, packed red cells if you want to correct blood loss or anemia. A simple way of moving the blood from the venous side, which in a normal person's got 80%, is just do a Trendelenburg. And just by lifting the legs up, it'll transfuse about 10% of fluid into the circulation. So in an emergency, have don't be afraid of lifting the legs, unless of course you've got a trauma to the spine, in which case you're going to have to deliver get a head down tilt like in number 2. So before you even think about cardiovascular drugs, just make sure that the tank is filled. In other words, your fluid is making no difference to the outcome. And now you've got to decide whether you need an inotrope, that is something to make the heart contract better, chronotrope, that will control the heart rate, either bradycardic or tachycardic, or a vasopressor, And really, the choice is lifelong learning. And I will attempt to give you some choices. And what we're trying to aim for is a mean arterial pressure of about 65 millimeters of mercury. Now, I'm a hypertensive, so I will require a higher MAP, and so will a patient with a head injury. So these are the sort of things that you need to adjust for when you're working out what is an ideal MAP. In hypovolemia, you don't need drugs. You just need to replace the fluid. In obstructive, you just need to treat the cause, because cardiovascular drugs are not going to make any difference. But in distributive shock, where things have gone pear-shaped, you can use venoconstrictors to reduce the venous capacitance and restore autoregulation. And in cardiogenic shock, you can use something like an inotrope to increase contractility, or a vasodilator to decrease the afterload, increase diastolic relaxation, increase or reduce the heart rate as dependent on. But the choice of which drugs you use, catecholamines being the sort of blunderbuss family name for these drugs, is difficult. Now, this is the simplest way I can describe how these drugs work. On the left-hand side, you can see the receptors involved: alpha, beta, beta 1, beta 2, dopamine, and vasopressin 1 and 2. I'm not going to go into in great detail now, because you need to sit down and read through this and understand it. But on your right are the drugs. You've got adrenaline, noradrenaline, dobutamine, isoprenaline, metaraminol, and vasopressin. And you can see that there are receptor activities, and you can see that each of those drugs have got a different profile. So your choice will depend on what is in front of you in terms of your individual patient. And this is another way of representing it. And the reason why I put this in, because you can see here, down here in dopamine, when you use it in low dose, 1 to 4 micrograms, you've got these effects. And as soon as you start increasing it, you get other effects. And then when you're on a high dose, you're getting purely alpha effects. So this is why dopamine in different doses gives you different things. And here, these are the inodilators, the vessels dilated to dilate the vessels, the vasopressors to shrink the vessels, inopressors to try and make the circulation tighter. But in simplistic terms, this is all you need to know. If you're septic, noradrenaline, and if you can just remember that, once these are the recommended solution, dissolving the concentrations that you use in your infusions. But you can see you start off at a certain rate, say 5 mils, and then you go up or down depending on the responses. So this looks complicated, but it's actually not that complicated when you understand really you're trying to titrate the rate with the response. If you're hypertensive, do you remember last week when Dr. Sanger from KCMC was talking about the hypertensive patient with the high heart rate? My first thought was labetalol, because that reduces the blood pressure as well as the heart rate. So this is the advantage of learning critical care from what we do in a critical care unit, and then how you transfer that into osteo care. And if the patient's hypertensive and you can't give beta blockers because, say, the patient's a very severe asthmatic, then GTN, distal trinitrate by infusion, will bring the blood pressure down. But the one thing I want you to notice here is I put hypertension, consider sedation, and anxiolytic. A patient can be hypertensive because they are awake and because they know they are ill, and perhaps they even know they're dying. So don't treat numbers. Look at the patient and have a very low index of providing sedation or an anxiolytic or an analgesic if you think there is a pain component. And we're going to discuss this in 2 weeks' time when we consider analgesia and sedation in the critical care patient. So treat the cause as quickly as possible, because this will dictate what the outcome for the patient. And the more you monitor, and especially if you've got a display monitor like this, where everything's there and you can look at trends, it's going to make it easier for you to see the changes, which can be sometimes even instantaneous. So in general, find the cause and give the specific treatment. The hemodynamic ranges, which you're going to get a lecture on this in the near future. Maintain the mean arterial pressure above 65. Make sure the tank is filled by keeping the right side of the heart at 8 to 12 millimeters of mercury, or the right side of the heart between 12 to 15 millimeters of mercury. And if you've got cardiac output monitoring, what you're trying to do is maintain a cardiac index of greater than 2.1 liters per minute per meter squared. Now, you remember the DO2, the hemoglobin optimization. We now go for 7 to 9 because really it's a balance between the macrocirculation and the microcirculation. The reason why low hemoglobins between 7 and 9 are good is because if you think of the viscosity of blood, if the hemoglobin is 14, the blood is more viscous than if the hemoglobin is 7. And what we are really talking about is blood arriving in the capillaries, the microcirculation. This is why for the microcirculation, we find that a low hemoglobin around about 7 is better than a normal hemoglobin. Keeping the saturation above 92%, the mixed venous oxygen tension about 70%, and trying to bring your lactate down to below 2. And as the patient improves, then there may be their brain, the neurological function in terms of AFU may improve, their urine output may improve. So you may see quite quickly if you are on a winning method. Now, this comes from the NICE guidelines from 2017. Apologies for this. We've talked about resuscitation, but you need to remember that these patients also need their routine maintenance of fluids, and also to consider other losses that may occur from vomiting, from pancreatic disease, from diarrhea, inappropriate urinary loss like in diabetes, etc. So we're not just talking about resuscitation, we're also talking about routine maintenance, and not just replacing blood, but also replacing fluids from other organ losses, which will contain electrolytes and can be quite challenging when you're on your own. Now, that's what happens in critical care. What happens in osteocare? Well, the minimum is really examining the patient, looking at the urine output, making sure they drink, rectal rehydration. You can get up to 500 mils rectally, or the WHO oral replacement solutions are pretty much balanced. May not be palatable, but you can disguise it with some fruit juice. And then you go through the monitoring to become better. Bleeding using a walking blood bank is done in the military, but it's not done in civilian practice because this is high risk if it's not done properly. So people have to be have the blood groups done and consent, and it's a big process. But I put in there because special forces would be doing that. And then obviously to make things tighter, epinephrine or phenylephrine or vasopressin as your vasoactive drug. And then on the best, basically, like I said to you before, targeted blood product resuscitation. Not just replacing the red cells, but also the clotting factors. Monitoring, I think you should look at the trend rather than a single observation. And I think it's much easier to understand what's going on if you've got it plotted on a chart. And that becomes very useful when you're doing telemedicine. The others all here, this provides you with a lot of information. And I've told you some of the limitations of lactate. So your primary interventions, wherever you are, if it's the mean arterial pressure, you're going to use fluids, make sure the tank is full, or make sure that the pipes are contracted or dilated, depending on what the situation is. Improving your cardiac output by filling up, making sure that the heart is pumping fine. If not, use an inotrope. Or looking at the resistance to which the heart has got to work through, in which case you need a vasopressor if it's vasodilated, or a vasodilator if it's vasoconstricted. And then you can control the hemoglobin, you can control the saturation by application of increasing FiO2 or applying PEEP, which becomes easier when the patient's ventilated, and reducing oxygen demand. I can't insist on this. If you reduce oxygen demand, then your supply is not as much a problem. So this is the basis for mechanical ventilation, the advantage of sedating a patient, the advantage of providing pain relief, the advantage of reducing the temperature for body, the advantage of cooling a patient that's got heat stroke. All these things will reduce oxygen demand. So you're trying to balance supply and demand. But for your mechanical obstruction, you just need to do the emergency appropriate treatment. And then you can be a little bit more sophisticated by just saying, what do you assess the patient when you first see them? Look at the global markers like lactate or CRT, or more regional things like urine output. Then use your vasopressors as we thought. If passive leg raise doesn't work anymore, then see if a fluid challenge will help. If not, you can make changes using ultrasound, looking at the diameter of the inferior vena cava, measuring the ejection fraction, and obviously trying to aim for a hemoglobin of 7, except in total traumatic brain injury or after a cardiac event where they say between 7 to 10, or if it's a refractory shock, 8 to 10. So basic hemoglobin is 7, but 7 to 10 if things are not going well. Again, this is the same thing, but in a different format. This is what is used in osteo environments, because the majority, perhaps with the exception of milrinone, are usually available worldwide. So in summary, you've got a bradycardia. You will use dopamine, neurogenic phenylephrine, septic norepinephrine, cardiogenic shock, one of those, and anaphylaxis adrenalepinephrine. So that is basically your summary. And then obviously you've got to treat your cause. And I don't make any apologies for repeating the emphasis on getting the basics right. Treat the cause, and then treat the signs and symptoms as you find them. Finally, I just want to talk about acute kidney injury and oliguria. We try and maintain a urine output of at least 0.5 mils per kilogram per hour. But this may need to be increased in cases like myoglobinuria or rhabdomyoglobinuria or heat stroke, because you've got a risk of the kidneys being sludged. And really, once the kidney has been damaged, although I said to you earlier, the kidney is less vulnerable than the heart and the brain, but if there is persistent oliguria or no urine for over 6 hours, then you run into problems. So now you don't have any kidney function. So really, going back to that chart from the NICE guidelines, you really need to replace maintenance and losses from the respiratory tract and from sweating. So in these cases, urine output cannot be used as an indicator, and you're going to find an increase in creatinine and blood urea nitrogen. So that is the 1 hour quick, brief overview of shock and how to make the diagnosis and the management. If it's obvious, it's easy to make the diagnosis. If it's subtle, it is very difficult. Management can be made easier if you just think about filling the tank making sure that the pump is working, and making sure that the pipes are tight or loosened accordingly. And I've got some slides that I want you to have a look when you've got free time. Approach to hemorrhagic shock, which I think is very useful, because it contains things like the ratio of blood to FFP and platelets, and it's got this flow chart which we've talked about. Here's Hagen-Poiseuille's law that we talked about, and then the different kinds of shock and what happens. And you can see the mean arterial pressure shock leads to multi-organ dysfunction, and the more multi-organ dysfunction you have, the higher the chance of you dying. And then vasopressors, this is a nice summary. When you've got time, just go through it. It'll hopefully make it easier for you to understand. And then a slide on lactic acidosis, because I think lactic acidosis, lactate as a marker can seem a bit easy, but you need to understand that it's not just the type A, which is the impaired delivery. It can also be impaired utilization, like you have in mitochondrial dysfunction. And there's a third group with bacterial overgrowth. And then finally, if you don't know what the hell's going on, this is where you start working out from first principles, whether it's a pump problem, it's a pipe problem, or it's a tank problem. And here, this is probably the most important diagram, because based on that, you can work out, and this you need to sit down and go through it in your slow time. Thank you for listening. I'm happy to take any simple questions.
Good afternoon, Dr. De Mello. Can you hear me?
Yes, Michael, I can.
Perfect. My question in reference to patients in severe septic shock that are showing signs of microcirculatory failure, say, for example, there is full body mottling.
Yeah.
They are in respiratory distress with evidence of crackles, so a suspicion of developing pulmonary edema, but have an adequate blood pressure, which we know at this point is not necessarily an indication of good perfusion.
Yeah.
When is appropriate to initiate vasopressors on this patient? Because I understand that the first step should be to fill the tank, but if there's concern of fluids in the lungs, maybe a fluid bolus might not be our desired intervention. Would it be appropriate to start a inotrope or a pressor at this point? Would it make any difference?
I think first of all, Michael, that's a very good question. Okay, because you're giving me a case where somebody is survival is at stake. So my answer to you is that if you think that this case was, say, septic, let's take sepsis, because that's a big killer. Okay, the chances are that you and I, working in AOE, will have patients who present late. So you're going to be in a situation where you've done all your basics, you fill the tank, the heart is contracting as much, and you think you've done everything you can. Unfortunately, blood pressure on its own doesn't tell me anything. It's a number. I can give you a bolus of phenylephrine and put your blood pressure up, and it doesn't help you, but it helps me, because I think I'm feeling better that your BP has come up. So the answer to your question is you fill up the tank, you assess the situation and look at what you can alter. So check the contractility and then check the SVR, PVR, which you're going to know more about later when you talk about hemodynamic management. Now, let's say for sepsis, noradrenaline is your number one drug to go to. Okay? Norepinephrine. I keep saying adrenaline. Norepinephrine. That's your number one vasopressor, and you're working your butt out, and you still think you're losing. The patient's mottling, they're not doing well, the skin is looking rubbish, they've got signs of coagulopathy or whatever. I would say, if you've got vasopressin, give it a go.
Okay.
So really, what I'm saying is, go by the Bible, But then if nothing's working and you think you've got a patient that's slipping on you, then I think you've got to go for big guns. And vasopressin would be an obvious one, because vasopressin doesn't rely on those receptors that you've been messing around with in your intervention and in the disease process. It's working on the vasopressin receptor. Do you understand? So if you've been messing with the alpha dopamine and beta receptors in the process of resuscitation and management of this patient, and it's now refractory and nothing's working, yeah, by all means go for vasopressin, because that's probably the only thing that's going to help you, or help the patient, sorry.
Thank you. Makes sense. Do you think that applying PEEP through non-invasive ventilation, say CPAP, would be indicated in these patients even if there isn't evidence of respiratory distress?
I think it's Michael, that's a very difficult question to answer. The reason why I find it difficult to answer is because I have seen so many patients during the COVID pandemic on the critical care unit, because I was working on the critical care unit during COVID, and I really felt as a doctor, as a person, knowing what I know about medicine, I think that is one of the most uncomfortable and most frightening interventions to do in somebody, because it's tight, it's claustrophobic, it's hard work, it's increases the work of breathing. So some patients will do well, like my 17-year-old who was a tiny scrap of a body, but he did well. But a 48-year-old, a slightly obese guy, just could not cope with it. So I think in your location, if you can apply 5 centimeters of PEEP in a non-invasive way, it's better than applying no PEEP, because the only way you're increasing your oxygenation is FiO2 or PEEP. And we know that high FiO2s are not good for you.
Perfect. Thank you very much.
Anybody else? Aaron?
Hi, Winston. I just have my phone off. I'm just wondering. Where you are in a taking blood culture. What's your personal line of where you are giving antibiotic versus holding off? Do you have a specific line to draw, or is it very much case by case?
Aaron, you broke up very throughout that. Just repeat it quickly.
Yeah, so just with a septic shock patient where you don't have access to taking blood cultures, what is your line of giving a broad spectrum antibiotic versus
the reason why I haven't put anything on septic shock is because there is a huge variation in practice between North America and Europe. So my answer to you is give the most appropriate antibiotic you have available, broad spectrum antibiotic, because they're going to die.
Yeah. So
yes, and this is why I think before you go on ops, whether it's military or civilian or disaster relief, I always check the CDC and check what antibiotics are recommended for the diseases prevalent in that area. So I've got in my mind or not in my mind, on my file of facts, because that's I'm old, I don't work on computers. I have a list of antibiotics I'm going to give to somebody when things are gone pear-shaped. So yes, the answer is you are better off in a suspected sepsis refractory shock, giving them a broad spectrum antibiotic, the best cover you can give at your location, because that's the only thing that's going to potentially treat the sepsis rather than treat the manifestations of sepsis.
For sure. Okay, thanks.
Jennifer?
Hey, Dr. Winston.
Yep.
Lots of info here to take in, but my question that I've kind of been a bit stuck on is so TXA is like a big topic at work, and especially I'm not sure if you've had a chance to read the HALT study that kind of came out, because I was just looking in this graph and it said like maybe you could use TXA within the GI bleed, but where you are, especially being like remote, my question is kind of what's your thoughts with regards to TXA in a very remote area with like if if you don't really have any blood nearby, so say, you know, it's a couple hours to get to the hospital or whatnot, just because since that HALT study came out, basically they said TXA is not beneficial in upper or lower GI bleeds. So the kind of consensus around my work is no TXA for GI bleeds.
Okay, so where do you work?
I work in the Yukon.
Okay.
In Canada.
Okay. So basically there are two issues. I'm not sure why this is correct. TXA had a fantastic effect in trauma, and now it's sort of, you use it routinely in trauma, major trauma. Okay, we also use it routinely in obstetric hemorrhage. So I'm giving a lecture on obstetrics in 2 weeks' time to the undergraduate course, and TXA comes into that. The issue becomes, I'll make it even simpler. In a heavy menstrual blood loss, TXA is used by gynecologists. Okay, so what I'm saying is, if there is a blood loss which can be controlled by TXA, the ones that are proven is being trauma and gynecological bleeds. The other areas, some have even gone berserk and applying it in plaster, in poultices on superficial wounds and stuff. But really, my advice to you would be to follow your regional or your state rules on the TXA use. I certainly would not use it for any other bleed, because quite often GI bleeds are very complex in that if the bleed is coming from an ulcer or from the erosion of a vessel, or if it's coming from a variceal tear, like in severe alcoholics, you're unlikely to sort the problem out by using TXA, because everything's so hypercoagulable at that stage. So I would say limit TXA to trauma and to obstetrics, stroke gynecology. But I'm not saying other people don't use it, but I'm just saying in terms of its safety, I would say TXA shouldn't be used for GI bleeds. Okay, well, thank you very much. It's 8 minutes past 6 home time. Don't forget to send in your Gibbs reflection. I haven't received any from last week from Dr. Sanger's presentation. It doesn't have to be big, but I can't believe that for any of the presentations you've heard and you're going to hear, there isn't something that you've learned or something you think that is totally wrong. And both need a Gibbs reflection, because that's the only way I'm going to learn about anything new, because as I said right at the beginning, I'm biased. Ibrick, all yours.
Thank you, sir. Any admin questions from you guys?
It's okay.